When mental illness drives filicide, responsibility, care, and justice. When a parent, while in the grip of severe mental illness, kills their children and attempts suicide, how should we weigh the reality and impact of that illness against the irreversible harm done to non consenting children? And what combination of understanding, responsibility, treatment, and justice best serves both the individual and society? These cases are rare, yet they force a collision between empathy and accountability that most moral and legal frameworks prefer to keep separate. They expose the limits of psychiatric care, the difference between short term medical stabilization and longer psychological work, the weight of parental duty, and a quiet institutional paradox. The state that takes custody of the surviving parent must then work hard to keep that person alive. The psychological reality. Severe postpartum psychosis or related states can dismantle ordinary reality testing. A person may hear voices, hold fixed beliefs that the children will suffer if left behind, or experience a compressed mental world in which death appears as the only coherent solution. The capacity for suicide itself is distinctly human. It requires self reflection. Experts such as the German clinician Wolfram Dormann have long treated suicidality as something that can be engaged therapeutically rather than merely managed or moralized. Ambivalence is common even in high lethality attempts. Survival does not prove the intent was insincere, it simply leaves the person facing the consequences. A frequent practical failure lies in the mismatch between what patients expect and what different professionals are trained to provide. A psychiatrist is a physician whose primary tools are diagnosis, differential medical reasoning, and medication. Psychotherapy training for psychiatrists varies widely and is often less extensive than the multi year specialized training of a psychological psychotherapist. Many people in crisis assume the psychiatrist will talk in the sustained sense of psychotherapy. When that does not happen, and when medication side effects or incomplete response accumulate, the sense of not being heard can deepen despair. Medication can be life saving in acute psychosis or severe melancholic depression. Yet the problems that culminate in these tragedies usually develop over months or years. Short term pharmacological stabilization, often measured in weeks to a few months, addresses immediate danger. It does not automatically resolve loneliness, meaning, relational patterns, or the cognitive constriction that accompanies suicidal states. Research on recovery in schizophrenia and related conditions has shown that reducing isolation and strengthening ordinary human connection can meaningfully lessen symptom burden for many people. That insight remains underapplied. Integrated care, medication when indicated, high quality long term psychotherapy, and real social support offers the best prospects. Purely medical or purely narrative approaches each leave important dimensions unaddressed: agency, responsibility, and the children. Children are not participants in any decision. They lack the capacity to consent to death. Parental responsibility is real, even when ownership is not. A parent's profound illness can diminish moral and legal agency without erasing the fact that the children are dead. Altruistic motives, believing the children are better off dead or cannot be abandoned, are clinically recognized in some filicide suicides. They do not restore the children's lives or transform the act into a shared fate the children chose. The other parent's role belongs in the picture without collapsing into simple blame. In many households, the primary caregiver carries the bulk of intensive daily labor. Isolation amplifies risk. A short, ordinary absence by the other parent does not equate to prolonged abandonment. Yet broader patterns of uneven caregiving and inadequate support systems remain relevant. Shared responsibility for children's welfare and for supporting a struggling partner is an ethical baseline. It does not convert every absence into causal equivalence with the acts themselves. Stereotypes that swing between all mothers are potential monsters and romanticizing the act as tragic autonomy both fail. Gender essentialism ignores base rates and the fact that the large majority of parents with severe mental illness never harm their children. Treating illness as pure social construct understates biological and phenomenological reality. Social context matters. It does not dissolve the illness. Treatment possibilities and systemic limits. Better detection, earlier intensive intervention, continuous monitoring of medication response, and genuine access to sustained psychotherapy might have altered some trajectories. Systems often deliver fragmented care: brief psychiatric contacts, revolving medication changes, limited therapy slots, and insufficient attention to the caregiver's isolation. Long term problems tend to require long term responses. The data on short term interventions can skew the picture of what lasting recovery demands. Once a catastrophe has occurred, the therapeutic task shifts. After acute stabilization, work typically includes rebuilding mentalization, the capacity to understand one's own and others' minds, processing trauma and guilt without premature forced insight, grief for the children, identity reconstruction under conditions of irreversible loss and often physical disability, and relapse prevention. This is measured in years. Medication frequently remains necessary. Psychotherapy addresses what medication cannot. The legal and institutional awkwardness. Legal systems ask whether, at the time of the acts, a mental disease or defect left the person without substantial capacity to appreciate the wrongfulness of the conduct or to conform conduct to the law. A finding of lack of criminal responsibility usually leads to secure psychiatric commitment with periodic review, not release. A finding of responsibility can lead to lengthy imprisonment. In either setting, the institution assumes a duty of care that includes preventing suicide. This produces a recognizable paradox. The person has already demonstrated willingness to die in connection with the same episode. The state then invests resources to keep that person alive. The refusal to allow completion of the suicide and the absence of capital punishment in many jurisdictions reflect two separate principles. The community still treats the children's deaths as demanding containment or accountability, and the community declines to authorize the state to kill or to stand by while someone in custody dies by suicide. The arrangement can feel absurd to the person living it and to observers. It is deliberate. Historical episodes of collective death during sieges or anticipated enslavement occurred under extreme external coercion. They do not map cleanly onto contemporary civilian settings in which mental health services, however imperfect, exist and in which the children's independent futures are not foreclosed by invaders. Those parallels illuminate helplessness. They do not supply justification. What remains? No single response dissolves the tensions. Accurate assessment of capacity at the time of the acts matters more than public emotion. Secure long term oversight prioritizes safety. Integrated treatment that takes both biology and psychology seriously improves the odds of preventing future cases and of making residual life livable. Prevention through earlier, better supported care for parents, especially those isolated with young children, remains more effective than any sentence after the fact. The children's deaths are irreversible. The illness can be profoundly real. Empathy for the depth of suffering that can drive such acts is compatible with clear recognition that the children were not authors of the decision. A serious societal response holds both truths without collapsing into either crude condemnation or sentimental absolution. The question does not yield tidy answers. It does require that we keep asking it with both precision and humanity.